Good evening. On behalf of Nari Division of Jackson Park, we welcome you to the Journal Club today, up to date with updates. This is organized by Haryana chapter of ISAR. From Nari Division, we present to you Cystilia M, formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol to restore ovulation and reproductive health in women. We also present Lycored M tablets of natural lycopene fortified with N-acetylcysteine enriched with CoQ10 and L-carnitine. For added advantage to win the race, Lycored M contains two proprietary complexes, natural lycopene as lycobeads from Israel, L-carnitine and L-tartaric acid in the ratio of 2:1 to give highest available L-carnitine as Carnipure, sourced from Switzerland. A warm and hearty welcome to all the esteemed faculty and attendees. The chairperson, Haryana chapter ISAR, Dr. Jyoti Malik, and Director Roots IVF at JJ Institute of Medical Sciences, Bahadurgarh. We welcome you, ma'am, and request you to kindly initiate the program.
Thank you so much. Thank you, Dr. Deepika. Thank you, Jackson Paul. And welcome to Up to Date with Updates, episode 6. And we from team ISAR Haryana with our tagline of Prayas Evam Vistar, Secretary Dr. Meenu, Clinical Secretary Dr. Manju, and Treasurer Dr. Laxmi welcome you to this discussion on 2 articles from Fertility Sterility. And we have the blessings of our think tanks of ISAR, our ISAR President, Dr. Ameet Patki, sir, who is consultant at Khar Hinduja Surya Hospitals and who's Associate Professor at Somaya Medical College. And with his sort of so much of experience, so many publications and 50 chapters in book, and with his constant support, we are making these small moves towards further refining our knowledge. So thank you, Dr. Ameet Patki, sir, for giving the opportunity. And then we have our Secretary General, Dr. Asha Baxi, ma'am, who is always a pillar of strength and support to us. She is the Honorary Secretary General. She is lead consultant, Dr. Asha Baxi, Fertility Center, in association with the Motherhood Hospital Indore, and she has been the Vice President of the West Zone Foxy in 2022. Also, we have other think tanks, the immediate past President, Dr. Palshetkar, ma'am, President-elect, Dr. Sunita Tandulwadkar, Vice President, Dr. Madhuri, Patil, Vice President, Dr. Sujata, Chairman for Embryology, Dr. Charudutt Joshi, and Vice Chair, Dr. Keshav, Malhotra. So these are always our pillars of they are always the guiding force and the torch bearers for this educational program. And today we have a special guest today as our expert. And the guest is none other than Dr. Surveen Ghumman. So Dr. Surveen is she's a very thorough academic person who is a senior director, head IVF Reproductive Medicine, Max Group of Multi-Speciality Hospitals, Panchsheel, Saket, Paparganj, BLK, Gurugram. She's also the professor of School of Health Sciences, Ansel University, and you can read through the CV very briefly that she has authored around 9 books. She has more than 80 publications, and she's a program director for fellowship in reproductive medicine at Max Hospital. And she is presently the senior vice president of the Indian Fertility Society, that is IEFS. So welcome, Dr. Surveen, and thank you so much for taking our time and to join us as an expert for these 2 interesting topics that we have chosen. And for these, we have 2 presenters, 2 young presenters. We have Dr. Pooja Bhayana. Dr. Pooja Bhayana has been a past consultant at Nova IVF and she is presently the clinical director at Sonakshi IVF, Hisar, Rohtak, Jeend, and Bhiwani. She has done her fellowship from Ahmedabad, and she has done her advanced training in embryology at BACC, Bangalore. And she would be presenting on the individualized dosing of polytropin delta, whether it affects live birth and safety in IVF treatment, and individual participant data meta-analysis of the RCTs. The second presenter would be Dr. Laxmi Goel, who is IVF consultant at Cloud9 Fertility Faridabad, and she is also our treasurer of ISAR Haryana. And her topic would be the effectiveness of preconception weight loss interventions on fertility in women, a systematic review and meta-analysis. So very simple, basic, but very interesting, I think, topics are there. But before that, we would have word from Dr. Asha Baxi ma'am, and her word of blessings, wisdom, and guidance. Over to you, ma'am.
Thank you very much, Jyoti, for the kind words. And first of all, I would like to congratulate Haryana ISAR chapter for doing such good activities. I've seen your newsletters. I've been there for your installation ceremony, and now this the series, up to date series. This is an excellent series. I've been here before, and I think you are doing very good work. And I think Journal Club is the need for the time, because once you read these articles, you feel like yourself also your thinking process changes, and you start working with more of in a more evidence-based way rather than just doing it and all that. So I think it's a very good thing. So congratulations, Meenu. Congratulations to Manju, GB, and I'm sure the speakers today, Dr. Pooja and Manju, are going to do justice to the topic. They will bring out the salient points of it, and then at the end, the beautiful and intelligent Dr. Surveen, she is going to comment, and this is really how the programs should be. So all the best to you, and I'm sure it will be a very fruitful program. So thanks for inviting me, and I've got some other commitments, so I would like to say goodbye.
Thank you so much, ma'am. Thank you for your presence and support, ma'am. Thank you so much. So we start now.
A very good evening to all. First of all, I would like to thank Dr. Jyoti for giving me this opportunity to present the article in the Journal Club today. So this article is regarding polytropin delta, and this was published in September 2024 issue of Fertility Sterility, where Scott M. and Nelson et al. Have actually done an individual participant data meta-analysis of randomized controlled trials on polytropin delta. We all know that when we are stimulating a patient, ovarian response is actually the keystone which actually determines the clinical pregnancy rates. But when we are stimulating a patient, we are also afraid of that our patient should not land up in a severe ovarian hyperstimulation syndrome. This is something which we all are afraid of, being reproductive medicine specialists. So we have to make a balance between them, between the response the patient is showing and putting up what safety measures we can take for preventing ovarian hyperstimulation syndrome. That is why a lot of, I would say, all the people around are talking about individualized dosing for stimulating the patients. And different molecules that are there regarding the stimulation are gonal F, which is polytropin alpha, the recagon that we know as polytropin beta, and the newer one is polytropin delta, which is Recovel, which is marketed by Ferring. Now, what is this polytropin delta? This is basically a novel recombinant FSH preparation, which is uniquely expressed in human fetal retinal cell line by recombinant DNA technology. We all know when we talk about gonadotropins, they have an amino acid sequence, and this is similar in almost all. The alpha and beta subunits are similar, but the these gonadotropins, how do they differ? They differ in their glycosylation profile, which gives them their unique properties. And delta follitropin, because of its unique glycosylation profile, has a lower clearance rate and a higher ovarian response rate. And it is unique in the sense that various dosing algorithms have been devised to administer this drug, which are dependent upon the AMH as well as the body weight of the patient. So in this meta-analysis, it was an individual participant data meta-analysis of various randomized controlled trials that was undertaken. The eligibility criteria that was laid down by the authors was that they should be selecting prospective randomized trials, double-blind or assessor-blind trials. Double-blind means the investigators were blinded, the patients were blinded, the embryologists were blinded. The studies that involved women undergoing IVF with fresh embryo transfers, and studies comparing the efficacy of follitropin delta with follitropin beta or alpha for live birth rates. The outcomes that were seen in this meta-analysis, the primary outcome was a live birth rate, and the secondary outcomes were in terms of safety, in terms of treatment efficiency. In terms of safety, the secondary outcomes were development of early OHSS and preventive strategies that were required to prevent it, early moderate or severe OHSS, and delivered infant being alive at 4 weeks post-delivery. The secondary outcomes in terms of treatment efficacy were the total FSH dose required, the number of days the stimulation lasted, the dose change requests that were there in between the stimulation process, and whether at least one embryo was available for cryopreservation. So these were the primary and secondary outcomes that were looked into. This is the Prisma flow diagram of the process of selecting and excluding studies. A large number of studies were actually initially evaluated, and out of those, only 3 studies were included in the review. And these 3 studies were the ISAR, Stock, and Grape. These were 3 different groups, ISAR, Stock, and Grape. The ISAR group conducted their study in 2017, and this was basically in most of the parts of Europe and other countries. And it involved 1,326 subjects between the age of 18 to 40 years with the GnRH antagonist protocol. It compared follitropin delta along with follitropin alpha, and the primary endpoints that were looked into the pregnancy rate and implantation rate. The Stock group conducted another study in 2021, which was conducted in Japan, and it included 347 subjects between the age of 20 to 40 years. It compared follitropin delta along with follitropin beta. The primary endpoints that were studied were the number of oocytes retrieved. The third group, the Grape group, conducted another study which was mostly in China, South Korea, Vietnam, and Taiwan. It included 1,009 subjects, GnRH antagonist protocol, age 20 to 40, comparison between follitropin delta, again follitropin alpha. And the primary endpoints were pregnancy rate. So these 3 studies were basically which were included in the meta-analysis. So the meta-analysis included 2,685 women who undertook 2,682 cycles between October 2013 and May 2020, and the live births were followed up through to February 1, 2023. So out of these 2,685 women, 1,334 women were administered follitropin delta, and 1,348 were administered either follitropin beta or alpha. Now, as I said, that follitropin delta, it is unique in its dosing because the dosing schedule or the dosing algorithm has been devised depending upon what is the AMH of the patient and what is the body weight of the patient. In case a patient is having an AMH level of less than 15 picomole per liter, this is picomole. In case we convert into nanograms, it comes out to be around 2.08 or 2.09 nanograms per milliliter. In case it is less than 15 picomole AMH, the patient was given 12 micrograms of the dose. In case more than 15 picomole per liter AMH is there, the dosing is decided depending upon the body weight, 0.1 to 0.19 micrograms per kg, minimum dose of 6 and a maximum dose of 12 was given to such patients. If we compare the baseline characteristics of all these 3 groups, the groups definitely varied because there was ethnic differences. All these 3 had been at different regions. All these 3 trials had been at different regions. These were phase 3 trials basically for polytropin delta. The main thing that comes out is in the ester group, the patients had a higher baseline weight, whereas in the grape group, the patients had a lower age with a higher AMH level. So heterogeneity was there in these groups. If you look at the results, how they were interpreted, this is quite a cumbersome slide to see. I've divided this into 3 parts. Actually, the results were divided. All the patients had been compared who received follitropin delta and follitropin alpha and beta. Then subgroup analysis was done depending upon what was the AMH level. Low AMH level less than 15 and high AMH level more than 15. If you look at the clinical efficacy and treatment outcomes in all the patients, regardless of their AMH levels, it was seen that there was not much of a difference between any of the groups, follitropin delta and follitropin alpha and beta. But one thing was significant, that total FSH dose that was given to patients was significantly low in follitropin delta group. Now, along with, in case we go into the subgroup analysis, just look at the patients who had AMH more than 15 picomole per ml. The live birth rate was higher in these patients. There was reduced risk of both early OHSS and or need for preventive interventions to prevent ovarian hyperstimulation syndrome. There was reduced risk of early, moderate, or severe OHSS, and there was lower total dose of gonadotropin that was utilized. Although the number of days that were given for stimulation were higher in these patients, but still the total dose that was utilized for stimulation was lower in the delta group. So these were the primary outcomes. These were the main outcomes that were seen in patients who were having AMH more than 15 picomole per ml. This is how this looked into. The live birth rates were higher. The total FSH dose, this was significantly lower in case of polytropin delta. Number of days of stimulations, they have written, I was confused in this, they have written equal 9 and 9, but p-value has been given to be less than 0.001. I'm not sure about it. But yes, overall, in case we talk about the safety profile, the safety profile was much better with follitropin delta because early, moderate, or severe OHSS or early OHSS risk was lower in these patients. Now, the second group, the subgroup analysis was in women with AMH less than 15 picomole per ml, but less than 15 picomole per ml, there was not much of a difference, but the follitropin delta was actually non-inferior to any of the 2 molecules, alpha and beta. There were similar live birth rates, there were similar safety outcomes, and this was basically for the group less than 15 picomole per ml. This is how the tabular forms looks like. So not much of a difference, except for even in those patients who were having lower AMH levels, the total FSH dose requirement was lower in follitropin delta, p-value less than 0.001. This is just the overall comparison that has been shown. If you look at this graph, almost all the graphs are like this only. This is the AMH level which has been put as a cutoff point, 15 picomole, this red line, dotted red line. And then this greenish is polytropin delta, yellowish is polytropin alpha beta. If you compare the live birth rates, not much of a difference in patients who are having less than 15 picomole. But in case you go higher, you go towards the patients who are having higher AMH levels, there is definitely a difference in the live birth rates. The live birth rates, if we look into the polytropin alpha, beta, and delta groups, AMH levels, there is a stratification of AMH level 0 to 15, 15 to 30, 30 to 60. And just look at this graph. In case you go lower down with the higher AMH, there is increase in live birth rates, whereas it is static with polytropin alpha or beta. Risk of OHSS was relatively lower with polytropin delta. This is the green line which is showing the risk of OHSS. Less number of patients had OHSS as compared to alpha and beta group. Live neonate at 4 weeks, when the AMH is higher, you have a better live birth, you have a better neonatal survival. I would say till 4 weeks, when the neonates had been followed, you had a better outcome in these patients. Number of days and FSH dose for stimulation, number of days that were required were higher in patients actually who were having polytropin delta administered, but total FSH dose is still lower. You look at this graph, number of days of stimulation, this green line is actually crossing the yellow line. So higher number of days of stimulation, but still the dose is required, but total dose that was required was less in patients with polytropin delta. Probability of having at least one embryo for freezing, still an edge over polytropin alpha or beta, polytropin delta, but this all depends upon AMH levels. AMH levels less than 15, the crux is AMH level less than 15, you don't have much of a difference, but AMH level more than 15, you have a better outcomes in terms of live birth rates, in terms of safety profiles for polytropin delta. So this is what I could find out in patients with AMH more than 15. Polytropin delta was associated with an increased live birth rate, improved safety profile in form of that the patients did not have mild or moderate or severe OHSS. There were less number of patients who had these adverse events. And the interventions that were required to prevent OHSS were less in polytropin delta group as compared to polytropin alpha and beta group. The doses that were required was much lower, significantly lower in polytropin delta group. And neonatal outcomes, if we see, there was not much of a difference between the two groups. So this is satisfying in terms of neonatal outcomes, that polytropin delta can actually be a replacement for polytropin alpha and beta as far as neonatal outcomes are concerned. But yes, there are limitations for this analysis. Why? Because the study populations, as I said, these trials were actually the phase 3 trials, which were all conducted by the companies themselves. So the study population was sourced from regulatory trials only. And we don't know how, in case we are giving it to the general population, how the outcomes are going to be. Cumulative live birth rates, there had been no data on cumulative live birth rates. Actually, what I could find, I tried to find out whether there was some gradation between the fresh and the frozen transfers, but nothing has been mentioned in all the 3 trials. And different AMHSs, we all know different AMHSs are available, and this was the Roche assay which was used. So we are still not sure किसी और AMH का ऐसे होएगा तो how it's going to behave. And starting dose of polytropin alpha or beta, the starting dose of polytropin alpha or beta was put to be 150, which was for all the patients, regardless of their AMH levels. So it could be argued that in case a patient is having a lower AMH, 150 could be a lower dose. In case a patient is having PCOS, a higher AMH level, then this could be a higher dose also. So the dose adjustments were not made regarding polytropin alpha or beta as far as the AMH levels were concerned. So blindly all the patients were given 150 units, and in between the doses were hiked depending upon the responses were. But still, as far as safety is concerned, I would say from this article, it is clear that live birth rates are good in case a patient is having more of a higher AMH. The safety profiles are much better. The doses required are lower. Although stimulation days are higher. So this is satisfying in the form of polytropin delta as a replacement for these two things. One of the trials, which was the GRAPE group, they have actually conducted an analysis on the number of oocytes retrieved. And it was very good to see that in case the patients who are having poor responders, who are actually poor responders, you get 2 more oocytes for your patients in case you are stimulating your patient with polytropin delta in the poor responder group. But in case a patient is having a higher AMH, more than 15, in those cases, you get 3 less oocytes, where actually this is actually preventive strategy for decreasing the risk of OHSS. That's all.
Very nice analysis of the whole paper. So what do you feel about the meta-analysis? You feel it's good? We should go by this conclusion. What is your take on it? You've been through the whole meta-analysis.
Yes, ma'am. Ma'am, one thing which I always take with a pinch of salt is whenever a company is conducting a meta-analysis or whenever the trials are company-based, it could be biased also. So yes, I would say we need to think what we want to plan, and there should be controlled trials with the clinicians, not company-based. So I would go ki apna experience kya kehta hai uske upar. But yes, trials are important. Companies have to conduct them, but then there can be some element of bias also.
Can you pick out the biases in this? Have you seen any?
Ma'am, that dose that I said, 150 units was the starting dose. So in case a poor responder comes to us, I don't think I will be starting with 150. In case the patient is having
so let's let's go by PICU. Okay, you understand what PICU is? PICU is whenever you analyze something, like when we made the guidelines for POR, we made PICU questions. PICU is population, which you're studying, the intervention, which you have done, the comparison, which you have done, and the outcome you have taken. Okay, so let's go bit by bit. What do you feel about the population which was taken?
Ma'am, the population was heterogeneous. It was basically the first trial, the ISAR trial was having European population more, and Russia was included. Then the grape trial was the grape trial was in Korean region, Taiwan, all these things were there. Asian region was there. And the third one, the stock, it was in Japanese population. So ethnicity definitely has, I think there is a role of ethnicity when we talk about the response of the patient. So it cannot be applied to all the patients.
Right. Have you gone through the individual paper, the meta-analysis?
Superficially, ma'am. Esther, I tried to study, but those two superficially.
To that, because when we did the guidelines, we went into each paper of the meta-analysis. So I opened the Japanese one, and I found that there, when they had written the demographic characteristics, age, FSH, antral follicle count, and all the other things which are associated, duration of infertility, cause of infertility, there was no p-value between the two groups, which means that they did not compare whether there was a statistical difference between the ages of the two groups, between the AMHs of the two groups. They had not done that comparison. That's the heterogeneity came in. Second thing was that when we analyze live birth as a primary outcome, right? You have to exclude all confounding factors which affect live birth. There was no exclusion criteria of severe male factor infertility, of a previous surgery on the uterus, of a fibroid, of anything affecting a live birth. So this is, whenever we write a paper or we give a thesis, we put this down as an exclusion criteria if we are seeing two comparators and these are the things which are affecting and our outcome is live birth or even pregnancy rate. So often you'll see papers going only till blastocyst rate, because they don't want to do the pregnancy rate. A whole lot of factors come in, like fibroids, adenomyosis, was the ET thickness at the time of transfer, difficult ET. So a lot of things come into play. So these were the two things which I found in population. Okay.
Right.
What about intervention? You've already mentioned one, that is the AMH. That we did the AMH with a regular Roche, this thing, but we don't know when we do it with something else, how it's going to come out. So again, if we apply this in the clinical setting, you are very right in saying that AMH as a cutoff for anything in a general population, it's very difficult to do because every clinic is doing a different kit. Nobody is not following only Roche. So how do we bring about a cutoff for this? That was absolutely right. But there were other things also. If you look at that chart where there was the chart which you showed of outcome and this thing, in that all three populations, they had agonist trigger written there. The first and the last had.
Yes, ma'am. I've seen that. And
when you go into the paper, they have said we have given agonist trigger and frozen all and excluded the patient.
yes, ma'am. Yes. This
Which-
is
which becomes such a huge confounding factor for OHSS,
right, ma'am.
right? So straight away, if you're giving an agonist trigger and freezing part of your study population, you're freezing the embryos, you have again brought in a huge confounding factor.
Right, ma'am.
Actually excluded the very severe OHSS by giving them agonist trigger and freezing and removing them from the study.
Right, ma'am.
So that was another thing which was very, very important. Then coming on to the comparison, one of the very, very important things is that here you are using a sliding scale, right? That you are altering it according to your patient population. The thin patient, high AMH patient, use a lower dose. And there you're giving a fixed regime.
Fixed regime, yes.
There is no comparison. If you want to say delta is better than alpha and beta, you have to give a sliding scale to alpha and beta also and then prove that delta is better.
Right, ma'am.
Right? So the comparison itself is not great. You understand? There is no comparison actually, because if you're not altering the dose of your alpha and beta, then obviously you will go into hyperstimulation. There will be a hyperstimulation happening. So it should have actually been that, yes, according to the weight, you alter the alpha and
Right,
then
ma'am.
delta better or not. And lastly is the outcome, right? They have said our primary outcome is live birth rate. But if you look at your charts which showed the outcomes, in all three studies, their primary outcome is not live birth
Not
rate.
live.
It is pregnancy rate, implantation rate, and number of oocytes, right? And how do you calculate your sample size? When you pick up a topic for thesis, let's say, you go to the statistician and you tell him that I want to calculate the sample rate so that my study is relevant. It is done by the primary outcome. Okay, so if the primary outcome has not been there in any of the three studies about live birth, that means your sample size was not relevant to the live birth. So your conclusion is also for live birth is not relevant because your sample size was not relevant. Listen, that is one of the things. And the other thing is very, very important. If you remember Seish Sankara's paper in 2012, which really changed our way of practicing. The more number of oocytes you have, the higher cumulative live birth you have. So here we have not calculated. They have taken into account one oocyte. Freezing one oocyte has been one of the outcomes. But beyond one oocyte, they have not. So if let's say I had frozen 10 oocytes, 10 oocytes, sorry, I had frozen 10 blastocysts, my cumulative pregnancy rate would be very high compared to somebody who freezes one. So that's also another very important thing because patient is not spending for drugs and time to pregnancy is much better actually with a cumulative live birth if you have a lot of frozen embryos lying there. So that was another outcome which was not considered. So now I want your comments on this. What do you feel?
We need to digest everything with our mind, using our mind, ma'am.
Let me tell you, when you really go into the studies, there's a whole lot you can pick up. And that's what journal clubs are about. Journal clubs are there to teach you people how to look at a study, how to analyze a study. And believe me, we when we did our guidelines, we had training programs for this. And we used to sit probably every evening discussing just these papers and these meta-analysis and how to analyze what is heterogeneity. So it's a big thing. And actually, when I clicked on their supplemental tables, it never went anywhere. They didn't have it on the net. Jahan pe they've written ki, okay, risk of bias you can see on the supplement table. I clicked. It didn't take me anywhere.
That was a great learning, Dr. Surveen. I mean, the way you have really made us understand what PICO is and how do we make this whole study and analyze with the PICO. It is something which we never thought of doing. And since you have done that POR, I think the whole complete reviewal of the POR studies. So maybe that is why, since as now once we've thought all these things, now next time when we analyze, we'll again start thinking in these terms.
So you know, we did so many. Yeah, we did so
Yeah.
many papers that I look at a paper like that now. Immediately, I'll just look at it and say, oh, this is this.
Yeah, so it is a critical analysis, and it is not just whatever they've published is all good or all true.
Yeah.
It is just that, okay, what they have done, but whatever, what wrong they have done is the critical analysis, which once we discuss it out and we talk about it, then we start realizing the importance of such, I think, papers. So that was wonderful. And now we go on to the next paper. Thank you, Pooja. Thank you. I think you had very less time. Only on Sunday, I told her that though we had decided that we are going to do it, but she had forgotten, I had forgotten, but our
And I had forgotten. When you told me in the morning, I said, oh yeah.
yeah. So we all had forgotten. And then on Sunday evening, she asked me कि वो है क्या? मैंने कहा हाँ वो है, because हमारा flyer बना हुआ है. And I once put the flyer on Sunday only. So that way. So it was a short time that she had got, but she's prepared it very well. In the very, very nicely. She has at least given us the gist of the whole paper, that at least what they are trying to say is that delta gives us better live birth rate, is safer, gives less of hyperstimulation, and lower dose is required. Though we have now that you have made us understand, they were just using 150 for everybody, and if they're using 150, then they should also do the same for alpha and beta also. So I'm sure people who have joined must have understood from what Dr. Surveen has. And for this, I would request that you be our expert for Journal Club every month. So let's see. Let's see. So thank you so much. If Dr. Laxmi is there, Dr. Laxmi.
Good evening, ma'am. So let's start with the next paper, which is about the effectiveness of preconception weight loss interventions on fertility in women, a systematic review and meta-analysis. This paper is from Fertility Sterility, September 24 edition. So it was done in the University of Colorado in US. So if we see why this meta-analysis is important, it is to see the effect of weight loss before conception. It is recommended for women with overweight or obesity to improve the fertility outcomes, but evidence supporting this recommendations is mixed. To examine the effectiveness of weight loss interventions using lifestyle modification and or medication in women with overweight or obesity on pregnancy, live birth, and miscarriage. The data source was an electronic search of Medline Embase Cochrane library, including Cochrane database of July 6, 2022. Studies collection and synthesis was a randomized controlled trials examining weight loss interventions through lifestyle and or medication in women with overweight or obesity planning pregnancies were included. Random effects meta-analysis were conducted, reporting the risk ratio for each outcome. Subgroup analysis were conducted by intervention type of control group, fertility treatment, intervention length, and BMI. The main outcomes were the clinical pregnancy, live birth rate, and the miscarriage events. The result was a narrative review, and meta-analysis were possible for 16 studies for pregnancies. N is equal to 3,588, 13 for live birth, and 11 for miscarriage. Women randomized and exposed to a weight loss intervention were more likely to become pregnant with a risk ratio of 1.24, but not to have live birth rate, risk ratio of 1.19, or miscarriage compared with women in control groups. Subgroup analysis revealed women randomized to weight loss interventions lasting 12 weeks or fewer, and women with a BMI of more than 35 kgs per meter square were more likely to become pregnant compared with women in the control groups. Miscarriage were higher in intervention groups who underwent fertility treatment. Conclusion was pregnancy rates were higher in women undergoing preconception weight loss interventions with no impact on the live birth or the miscarriage rates. Findings do not support one size fits all recommendation for weight loss through lifestyle modification and or medication in women with overweight or obesity immediately before conception to improve live birth or miscarriage outcomes. So we see that the prevalence of obesity among women aged 20 to 39 in the US has more than tripled, and severe obesity has increased tenfold between 1960 and 2014. Obesity increases the risk of cardiometabolic diseases and pregnancy complications, impairs fertility, and influences the next generation through increased risk of poor fetal outcomes and obesity in offspring. Therefore, weight loss before pregnancy or fertility treatment is routinely recommended. Weight loss through lifestyle modification, including caloric restriction and increased physical activity, is considered first-line treatment for obesity. But lifestyle interventions are intensive, tend to be less successful in women, have limited long-term efficacy, and lack convincing evidence supporting benefits for fecundity, pregnancy, birth, or fetal outcomes. Pharmaceutical interventions utilizing anti-obesity medications, that is AOMs, produce superior weight loss compared with lifestyle modification alone. But less is known about their impact on the reproductive health outcomes. 6 large-scale randomized controlled trials, RCTs, have been published since the most recent data synthesis, and prior reviews had methodological limitations that preclude definitive conclusions on the effect of weight loss through lifestyle modification and/or medications on fertility and pregnancy outcomes. The first systematic review only included studies of lifestyle interventions for weight loss in women before assisted reproductive technology, with conclusions supporting recommendations for weight loss before ART. A similar review and meta-analysis of weight loss on fertility or birth outcome in women undergoing IVF was published in 2017 and echoed the narrative reviews, finding that weight loss improved pregnancy. However, studies among women seeking infertility treatments are not necessarily generalizable to all women of reproductive age during desiring pregnancy. A 2019 systematic review was not limited to women undergoing ART and included studies using lifestyle modification, pharmaceutical and bariatric surgery interventions for weight loss. However, it only included a quantitative synthesis of weight outcomes rather than pregnancy or live birth rates. A recent meta-analysis found interventions combining the diet and exercise led to higher pregnancy and the live birth rates compared with women in control groups. In another, lifestyle interventions led to higher pregnancy rates, had no impact on live birth rate, but were associated with a higher miscarriage rate. These meta-analyses were used for per protocol analysis to calculate the pregnancy and the live birth rates rather than using intent to treat. Findings from recent large-scale RCTs question the efficacy of weight loss interventions for improving the fertility and live birth outcomes and raise concern about increased risk for women from the weight loss attempts before fertility treatment. An up-to-date and comprehensive quantitative synthesis that includes these RCTs and pharmaceutical interventions is needed to replace blanketed guidelines for preconception weight loss in women with obesity. To that end, we concluded a systematic review and meta-analysis that includes studies of women with overweight or obesity seeking pregnancy and the use of weight loss intervention, that is the lifestyle modification and or medication on the subsequent pregnancy, live birth and miscarriage. To overcome methodological limitations of the previous reviews, we used intent to treat principles to provide a more pragmatic real-world analysis of the extent to which being randomized and exposed to a weight loss intervention improves outcomes rather than successfully completing the weight loss intervention, appreciating that lack of compliance is common in weight management interventions, particularly in reproductive aged women. So in this particular review, the 2020 preferred reporting items for systematic reviews and meta-analysis guidelines were followed and registered on Prospero, inclusion-exclusion criteria, search category, strategy process used to evaluate evidence quality and meta-analysis methods are detailed below. So If we see the condition, population and the conditions, randomized controlled weight loss interventions in women with overweight, BMI of more than 25 kgs per meter square and less than 30 kgs per meter square, or obesity, BMI of more than equal to 30 kgs per meter square. Planning pregnancy were included. Studies that required pregnancy as inclusion criteria were excluded since pregnancy rates could not be determined. Cross-sectional observational studies, conference papers, abstract dissertations, and reviews were excluded. We did not include non-English articles. So what was the intervention? The weight loss could be achieved by any intervention, including lifestyle modification, diet, and or physical activity or exercise, and or pharmacological treatment. We excluded studies where the intervention was solely exercise, as exercise has many beneficial effects independent of weight loss, and this review focused on the outcomes of interest as they relate to weight loss. Included studies required a control group of any form to compare rates of primary and secondary outcome. So the outcomes, the primary outcomes was clinical pregnancy, defined as either pregnancy visualized by ultrasonography of one or more GSAT, or definitive clinical proof of pregnancy, that is by positive blood or urine test for HCG. Secondary outcomes were the live birth and the miscarriage rates. Study selection. Review and the selection of potential manuscripts were facilitated by Providence systematic review software. Identified records were imported and duplicates were removed. Titles and abstracts were screened in duplicate by independent reviewers. Manuscripts meeting inclusion criteria on the basis of title or abstracts were retrieved for full text review and screened in duplicate by the independent reviewer. So discrepancies in the inclusion or exclusions were resolved by a third reviewer or group discussion. How the data extraction was done, the following data were extracted by two independent reviewers from each manuscript meeting eligibility criteria, procedural, participant number, population characteristics, protocol for inclusion, randomization, number randomized, etc. And outcome data, that is the pregnancy or live birth or miscarriage events, using a specifically designed form. So statistical analysis was performed using R binary data were assessed using the log risk ratio, that is LRR, and random effects models. REM were used to estimate the average LRR given the heterogeneity of studies. The LRR was used for modeling because it was distributed closer to normal than the risk ratio. However, the ease of interpretation, the model estimated LRRs were then transformed into the more widely used risk ratio. Heterogeneity was evaluated using chi-square tests with p-values and I-square index values for each outcome. To explore the heterogeneity, we conducted subgroup analysis by study design characteristics, including the intervention type, lifestyle only or AOMs plus minus lifestyle, control groups, usual care, immediate fertility treatment or active weight loss, or intervention length, that is less than equal to 12 weeks or more than 12 weeks. Fertility treatment, yes or no. Baseline BMI less than 35 or more than 35, more than equal to 35. Further, given the heterogeneity among studies, we calculated a 95% prediction interval, which can be interpreted as an interval that would contain approximately 95% risk ratios calculated in similar future studies. All presented risk ratios are estimated from the REM as opposed to the raw data. The primary outcome was pregnancy, and all other analysis, both secondary and subgroup, were unadjusted for multiplicity and should be interpreted as such. So the results were, as we can see in this, initial from the database, initially screened studies were 4121, out of which 4054 were excluded, and then 67 were screened, again reports not retrieved, then 67 again assessed for eligibility. So final 16 studies were included in this meta-analysis. So if we have the list of all the 16 studies on the left side, and if we see this this forest plot, we see that 16 RCTs show that women randomized and exposed to a weight loss intervention had higher pregnancy rates, that is 42.1%, compared with women in the control group, that is 36.8%. Then in this forest plot, it depicts the impact of treatment on the pregnancy by intervention type. We see that the significantly higher pregnancy rates were observed in the lifestyle modification only intervention, that is 50.2%, compared with the control groups, that is 46.7%. Then we see the impact of treatment on the pregnancy by the control group. Higher pregnancy rates from the weight loss intervention was observed as compared with an active weight loss control group, but not usual care or immediate access to ART. Then the impact of treatment on pregnancy by intervention length. The weight loss intervention that were 12 weeks or fewer were associated with higher rates of pregnancy, 38.5%, compared with the control group, that is 30.7%. Then the impact of treatment on pregnancy by the baseline BMI. Interventions where the study population of women had an average baseline BMI of 35 kgs per meter square had higher rates of pregnancies in the intervention compared with the control. Impact of treatment on the live birth by the study. The overall live births were higher but not statistically significant. So in the intervention group, 34% compared with the control group, which was not statistically significant. If we see the impact of treatment on the live birth rate by intervention type, there was no difference in the live birth rate by the intervention type in lifestyle only or those including medications. Impact of treatment on live births by the fertility treatment. There was no differences by the control group type in the usual care, active weight loss control, or those receiving the immediate fertility treatment. Impact of treatment on the live birth by the intervention length. Again, there was no significant increase in the live birth rate by the intervention length. Impact of treatment on the miscarriage. By the study pooling results from the 11 studies reporting miscarriage rates, there was no difference between the intervention compared with the control group. Impact of treatment on the miscarriage by the fertility treatment. There was no impact in the intervention characteristics or baseline BMI on the miscarriage rate per participant. However, a higher miscarriage rate was observed in the intervention group as compared to the control. So we come to the discussion. This meta-analysis focuses on the randomized studies for preconception weight reduction in women with the overweight or obesity planning pregnancy. Weight loss interventions included those using lifestyle modification only and the addition or sole use of AOMs compared with different types of control conditions. Overall results suggest a beneficial effect in women randomized to lifestyle intervention without AOMs on clinical pregnancy rate. But there was no impact of weight loss interventions on the overall live birth or the miscarriage compared with control. However, women randomized to weight loss interventions and undergoing fertility treatment had significantly higher rate of miscarriage. So lifestyle interventions only were associated with higher pregnancy rate, but not the use of AOMs either solo or in conjunction with the lifestyle intervention. This review is notable for the addition of weight loss interventions, including AOMs. Little is known about the use of AOMs to achieve a healthy weight before pregnancy. Thus, this is a timely addition to the literature. New trials will need to examine the impact of more effective AOMs as well as the benefits and the risk of using these newer AOMs for preconception weight loss. Clinicians should provide appropriate contraceptive counseling to reproductive age women taking AOMs to decrease the potential maternal and fetal outcomes. Strengths of the study. Strengths of this review include subgroup analysis conducted by study and population characteristics. Enrollment into preconception weight loss intervention is complicated because of the competing demands of the advancing maternal age and the delaying infertility treatment, in addition to barriers noted in the general population, such as the availability of evidence-based program, time, cost, motivation, and perceived effectiveness and social support. Thus, the finding that weight loss interventions of less than equal to 12 weeks resulted in higher pregnancy rate is something to explore in future trials. Although the results was not quite significant, there was a trend towards more live births for women in weight loss interventions of less than equal to 12 weeks compared with the control. This amount of time may be more palatable for women of reproductive age wishing to conceive and is in line with the view, noting that different phases, preconception, active fertility treatment, pregnancy, requires strategic approaches for the weight management. Furthermore, study populations where the baseline BMI of more than 35 were associated with higher pregnancy rate in the intervention compared with the control. Although there are no available data on a weight loss threshold for improvement in fertility outcomes in women, our findings add to the literature the importance of identifying population characteristics in which weight loss may be more beneficial. In future, individual participant data meta-analysis exploring the treatment response by baseline BMI will provide crucial information for clinical practice. Limitations of the study there were several limitations of the current synthesis. First, we did not limit the population to interest of women undergoing infertility treatment or those not undergoing fertility treatment. Identifying a representative population of women seeking pregnancy is an inherent difficulty that must be overcome in future studies. Then, although the percent of variability due to heterogeneity in this meta-analysis was lower than we observed in 2%, in recent meta-analysis, the narrative synthesis details the wide variety of study population. Additional unexplored variables may influence the extent of which weight loss improves conception, live birth, and miscarriage. We were unable to conduct the subgroup analysis by PCOS or other causes of infertility, which may affect the extent to which the weight loss and interventions improve the conception rates. Finally, we were unable to pass out unassisted or natural conceptions with subsequent live birth and miscarriage rates compared with OI or IUI or IVF pregnancies. So these were the limitations. To conclude, our results suggest that there is no one-size-fits-all recommendation for preconception weight loss in women with overweight or obesity on fertility outcomes. A more nuanced and the personalized approach should be taken when recommending weight loss through lifestyle modification to improve the fertility outcomes. At the same time, adverse pregnancy and the perinatal outcomes associated with obesity pose serious risks for women and their offspring. Preconception weight loss should be supervised by clinicians with specific expertise in obesity treatment, especially with the increased availability of AOMs. Weight loss may need to proceed attempting conception for a longer interval than that used in existing studies, which may not be feasible in women with low ovarian reserve or advancing maternal age. Clinicians in primary care and OBS and gynae should provide patients the opportunity to thoroughly discuss the preconception health to weigh the potential cost and benefit of attempting the weight loss through lifestyle modification or AOMs before attempting pregnancy. Improving the preconception health of reproductive age women with overweight or obesity will entail conducting adequately powered, interdisciplinary, well-designed RCTs to generate more robust evidence. Thank you.
Thank you, Laxmi. I think that was also very well presented. Both cases, you people have really gone into the article and taken out relevant points. So, like we had discussed in the previous one, what would you say about this analysis? What is your take on it?
Ma'am, I would say that there were a lot of limitations as well in this study, because the weight loss intervention, especially in BMI more than 35, there was no mention of bariatric surgery for the as a intervention for the reducing weight. So, like, bariatric surgery is an important component in it, and also the AOMs were not specified which particular anti-obesity medications were used in different studies and which are safer to use.
In fact,
So
somewhere they've used metformin, somewhere they've used orlistat. So they've done different types of.
yes, ma'am. Right. So overall, I think this meta-analysis would require a lot of more studies, like different studies to see the effect of weight reduction by different methods, including lifestyle, AOMs, and the bariatric surgery to see the effectiveness.
So what do you feel about the population they have taken? Is there
They
something you should have specified?
they have taken the 16 RCTs. They have included 16 RCTs.
The women they have taken.
Uh,
What do you feel about it?
they have taken almost like most of the RCTs. I have not gone through all the RCTs as such.
Yeah, see, basically when they take a population which is planning a pregnancy and a population which is undergoing IVF, they are absolutely different populations.
Yes,
So
ma'am.
although they have done a subgroup analysis, but in their general analysis, it is totally different. Their live birth rates, their pregnancy rates are going to be totally different. If, let's say, again, I say that if it was a severe oligospermia or we were taking out a testicular sperm, it alters everything in the whole thing, you know. So you cannot combine these two populations in a meta-analysis. You have to separate them out. Secondly,
Right,
they
ma'am.
have not mentioned PCOS at all. Whereas
Yes, ma'am.
PCOS is one big chunk which really responds to weight loss. So you cannot take a PCOS population along with a PCOS population and not do a subgroup analysis.
Right.
Then, you know, whether age was similar, whether duration of pregnancy was similar, so many other things come into play. So these are things which in the population were not there. What do you feel about the intervention? You did mention a few things, but
Yes, ma'am. Intervention, again, there was no mention of the how much exercise, duration of exercise,
type
what
of ex.
yes, what type of exercise, lifestyle intervention will include all things, and then the AOMs, the bariatric surgery. So
Yes.
all that
And
was
also food. They're like there's somewhere there's they've used the glycemic index, somewhere they've done severe calorie loss for the food part of it, somewhere they've done replacement of calories.
right.
So it's so varied that and then the duration of the whole thing is varied. How long did the intervention take place? Kisi ka 4 weeks hai, kisi ka 8 weeks hai, kisi ka 12 weeks hai. So
Yes.
they put all these groups together, whereas there is so much of difference in the groups. What about comparison?
Comparison, again, ma'am, they have not like compared the overweight and the obese, two kind of populations that they have included.
No, no. Comparison means your comparison with the control group and with
Okay.
study group. So if you have a look, somewhere they have mentioned that control group in 4 studies had also undergone some kind of a weight loss regime, but it was not that strict. So
Right.
again, that doesn't form a good control group. There were 4 studies like that, which they had taken, which had a control group, which was also doing exercise, etc. So
Right.
that comparison is not very good. Also, when you are doing a comparison, if you look at there was a column of retention rate. Okay, that means how many people stayed in the program. And that varies from 59% to 100%. That means in some studies, 59% patients left that study.
Right.
That again forms a huge confounding factor. Okay.
Right.
And then one very important thing is heterogeneity. So at the end of all your graphs, all these forest graphs, there is an I2. If there's an I2 along with a P value.
Yes,
Now,
ma'am.
if this I2 is more than 50%, that means you're dealing not only with a heterogeneous population, but a heterogeneous intervention, a heterogeneous comparison. So the study becomes poor. And all the forest charts, except for one which has 49, has heterogeneity over 50%.
Okay.
All of
Hmm.
and their paragraph on bias showed that in 15 studies there was a high risk performance bias. What does performance bias mean? That either they were not randomized properly, or the clinician favored taking some patients, or the intervention was not done properly. Acha, kal tum exercise nahi karo. So that is performance bias. Okay, so 15 studies had performance bias. 3 studies had attrition bias. That is that the patients left the study, and there was a substantial amount of patients which left the study to affect the results of the study. And one had a selection reporting bias. That is, the people who are writing it, they report it in such a manner that they want this result to come out. So there's a bias in that. And when you analyze it, there's a bias.
Okay.
Coming on to the outcomes, very important. What was the outcome?
Yes, ma'am. The only thing, the outcome which was significant was that the duration of less than equal to 12 weeks of intervention will increase the live birth rate. But there is no increase in any clinical pregnancy rate. Clinical pregnancy rate is there, but no live birth rate.
Rate, but doesn't increase the live birth.
Yes.
Right? And it doesn't change the miscarriage rate.
Right.
So ultimately, what are we looking for? We are looking for a live birth rate.
Yes. Right.
If the studies on pregnancy rate, it really does not translate into live birth rate.
Yes.
So, would it make sense to make a woman of a low AMH or a higher age wait for 4 months to increase her weight and then take her up? No, it doesn't. So at the end of the study, actually the conclusion is that don't wait.
Yes. Right.
So, and one very important thing which they haven't told is the weight loss threshold. They're talking about weight, but they haven't stratified into 5 kg or percentage weight loss. The results in, let's say, 10% weight loss is this much, and the result in 20% weight loss is this much, and 5% weight. Very important, because where are you going to tell your patient to stop? Okay, stop weight now. It's okay. We've reached that optimum level, and it's not affecting your case. So that is also very, very important, that they should have stratified according to the amount of weight loss, percentage of weight loss.
Right.
So
I think you highlighted very, very good points, ma'am. Very nicely. So I did not think that much.
Yeah.
Actually, we've not thought that much every time, Dr. Laxmi, we just present it and we just think कि okay, जो ये बोल रहे हैं सब ठीक बोल रहे हैं और हमें ये लेना चाहिए. लेकिन अभी हमें डॉक्टर सुरवीन ने हमारी आंखें खोल दी हैं, है ना?
I hope
study में से I don't think, Dr. Surveen, if you are the analyst for that study, 80% of them you would reject and put into the bin.
You know, Jyoti, there are some studies which are so good कि उनमें कुछ निकाल ही नहीं सकते हो. They are very good, some studies.
Yeah. No, but once we just go through all these studies, then we'll start understanding which are good and which are bad. So this exercise we have to do with our minds and with our analysis. So that analytical skills have to develop once we interact like this on a platform like this. So I think it was a real good discussion today we have with your presence, because we started our thought process on the PPO, because we never actually analyzed any of our studies on that basis. So I think if we analyze using that, each of those 4 tools, then we can make out whether the study is good or bad. So that is a perfect way to analyze that paper. And I'm sure, though not many people are there, but once we put this recording on the group, and Dr. Pooja and Dr. Laxmi, we can at least in our Faridabad and ISAR, if we can ask them to at least go through this recording, I think it will be very, very beneficial.
Yes,
because,
definitely.
Because we have done this exercise but let people also start understanding the importance of this, and that exercise that we are doing will be much beneficial if we do it analytically that way. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, Dr. Deepika. Thank you, Jackson Paul.
Before we close, I'll just like to take you through our two of our products, Cystelia M for women suffering from PCOS and associated infertility, myoinositol, dechiroinositol, 40:1 ratio, and Lycored M, the tablets for male infertility, which has the added advantage of N-acetylcysteine, L-carnitine, coenzyme Q10, lycopene, zinc, and selenium. So we hope to see you again next month in the same series. Thank you. Bye-bye.